Hi. Hi, good evening, everyone. So today is our first time with Dr. Kang. Dr. Kang is actually an endocrinologist with Utah, and he also practices in Beacon Hospital and a few other private centers. He is a UNIMAS graduate and did his postgraduate through MRCP, which is actually the parallel pathway. And then after that, did his endocrinology training in UKM. HUKM, right? Okay.
Yes.
Welcome. This is the first time, and actually somebody requested for this webinar, diabetes, how to treat diabetes in the elderly. And I was thinking about it, there are a lot of differences, I think. And without further ado, come, let's start.
Okay. Thank you so much, Dr. Betty, for your invitation. Okay, so I'll start the ball rolling. So the topic given to me today is treating diabetes in the elderly. So I have no conflicts or interest for this talk. So my talk will basically rotate around two big topics: is why we should treat diabetes in the elderly, and how we should treat them. Okay, how different is it, and what are the other things that we need to consider while treating this cohort of patients. So first of all is, why should we treat diabetes in the elderly? As we know that diabetes is very prevalent in Malaysia. So the latest National Health and Mobility Survey showed that around 1 in 5 Malaysians are diabetic. But if you look in the data clearly, it's actually 1 in 3 elderly Malaysians are diabetic. So 1 in 3 elder people, one of them probably is diabetic already. And the definition of elderly actually varies according to countries. So some will take 65, and for this NHMS survey, they took 60 years old. So for Malaysians above 60 years old, 1 in 3 are diabetics. As the whole world is aging, and this figure is bound to rise in years. So in the future, we might expect more and more diabetic elderlies to treat. Up to 60% of deaths globally are directly or indirectly due to diabetes. So diabetes itself, as we used to say, is mother of all diseases. Elderly diabetic patients, they have a higher risk of complications.
Do you mind sharing your slides as you talk? Sorry.
Oh, I thought I'm showing already because it's appearing in my slides.
Oh no, we don't see it.
Oh, let me try again. Okay, Zoom. Can you see now?
Yes.
Okay, so sorry again. So back, yeah. So as I was saying, elderly patients, they have a higher risk of getting complications like the kidneys, the eyes, and the blood vessels, and the heart, etc. And aside from that, there is this thing called a geriatric syndromes, where there is a constellation of diseases or symptoms that exist in the elderly population. And of course, we know that elderlies, the cost of medical expenditures is of course higher among these people. Okay, so this is just another one to show that from the NHMS survey, okay, 1 in 5 are diabetes, but if you look at the data here, okay, a lot of them are actually more than 60 years old. So a lot of diabetics in Malaysians are actually more than 60 years old. Okay, so then we go to the main part of this talk is, how should we treat diabetes in the elderly? So in the general population, we know that diabetes, you talk about lifestyle intervention, and if the diabetes is poorly controlled or there are the risks of complication, you want to prevent beta cell failure, you will start early, aim for A1C 6 to 7.5%, etc. So how is this actually different from treating the elderly population? So what is so special about this geriatric population is that 60% of them have at least another comorbid disease. So they will have something else. They might have ischemic heart disease, hypertension, kidney problems, gout, and any other things. Okay, visual impairment, etc., osteoarthritis, etc. And if we look at the data, up to 40% of these patients, they have more than 4 concurrent illnesses. They may have other things, malignancies, etc. So to treat this kind of patients, you need to have a lot of considerations, okay, especially with the presence of geriatric syndromes. For instance, here you say that you may have cognitive decline, memory impairment, they may have mood problems, they feel depressed, other things like polypharmacies, they might be taking lots of medications per day, they may fall easily, break their bones due to osteoporosis. Because of osteoarthritis or the fractures, they may be unable to walk, they may be bed-bound, they may have a high risk of urinary incontinence or benign prostate hypertrophy in males, okay, and cardiovascular diseases and others as well. So this group cluster of symptoms or diseases, we call it geriatric syndromes. So cognitive dysfunction and depression is quite prevalent in the elderly as well. And as we know that diabetes is actually associated with cognitive dysfunction. When you are diabetics, you have a high risk of getting a stroke, which may render you susceptible to getting a dementia, a vascular dementia. So in these kind of patients, one thing is that they may have issues with compliance. They may forget to take their medication, hence, therefore, their sugar control is poor. Or they may forget that they have already taken medications. So they take it more than once and they end up with overdosing. And with that, increased risk of severe hypoglycemia. And the more hypos you get, the more likely you'll get infarcts in your brain. So it may become a vicious cycle. A stroke patient has memory problems, get hypos, and then the strokes worsen, then the memory problem is even worse, and the hypos get even worse, and it's a never-ending story. And for depression, sometimes they may feel depressed and they don't want to take care of themselves and may cause their diabetes to be more severely, more poorly controlled. Other things may include disability. Okay, they may be unable to walk, so no exercise. They may just sit whole day. Okay, other things like sarcopenia or bone fragility. They may be easier to get fractures if they fall. They may have gait disturbances, unable to walk. When they get hypos, they may fall. And also, they may have urinary incontinence as well. So, these kind of patients, if they are bedbound or things, they are high risk of getting UTIs. If you put them on certain medications like your SGLT2 inhibitors, then this patient may get higher risk of genital infections or urinary tract infections as well. And we know that elderlies, a lot of them succumb to UTIs where they end up with deliriums and then a prolonged hospital stay, etc. And other medications like metformin or GLP-1 receptor agonists, they may actually cause anorexia. So the patients may have a poor appetite, they don't eat well, and they end up losing muscle bulk, which worsens the sarcopenia. Other issues will include overtreatment and polypharmacy. So polypharmacy is defined as a patient taking more than 5 medications a day. So if you look at our elderly, they take hypertension, probably 2 pills, diabetes, another 2 pills, aspirin, statin, and their own calcium, vitamins, iron, and a lot of tablets. So they may get confused. And this will cause compliance issues, especially when the therapeutic regimens is so complicated. For instance, metformin, 2 tablets morning, 2 tablets night, add on with glycoside, 2 tablets morning, and then you have SGLT2 1 tablet daily, with aspirin daily, prandial daily, and statin at night before sleep. So there are so many pills the patient may have difficult to remember. And of course, not to forget drug interactions. So some medications like allopurinol or warfarin, they may interact with our diabetic meds, although their chances are a bit small. And other herbs, like some they may take grapefruit juice, others, etc. So all this can cause drug interaction and lead to hypos or inefficacy of the drugs. And lastly is we talk about glycemic control. So yes, we want to treat our patients, but how tight should be the glycemic control be? You want to make it very tight, aim for A1C very low, but then again, the patient will complain that, no, doctor, I have no quality of life. I'm already 80 years old, I cannot enjoy food, I get hypos all the time, it's worse than dying. So patients might prefer to have a better quality of life versus a stricter glycemic control. So there's always this dilemma of balancing. You want to control the sugar or you want to let the patient be happier. And of course, because of their high vulnerability to low sugars, you might want to be a bit cautious and not to be too strict on the sugar control. Okay, another aspect is that the elderlies, not all of them are the same. We have a cohort of elderlies who are what we call the community dwelling elderlies. So they are basically independent, high functioning, which their memory is still good. They are able to be independent, do their own things, go to the market, go out on their own, drive. Okay, medically stable. They have no comorbids. So the challenges of this group of people is that you can give them complex regimens, but they can be quite rebellious. They might not want to follow your advice. And when this group of patients, although they are stable, but whenever they have acute illness like AGE or a severe UTI or anything, it can cause acute deterioration in the cognitive or physical function. And sometimes if they stay alone, you might need to frequently educate them or counsel them, and again and again and again reinforce them, especially if they stay alone. So in this group of patients, our aim is that we want them to have a good quality of life, and of course we will want them to control their sugar profile as well, in order to prevent future macro and microvascular complications. So in other words, you want them to live happily, but again, you don't want them to develop kidney or heart complications. So it's a balance. Okay. And you have another group of elderlies who are not as fortunate. So they may be residing in an assisted living facility, maybe in a family, staying with family, taken care by their families, or they might be staying in a nursing home or elderly retirement home. So their functional level can be as low as completely dependent, or they can still be highly functional. And some, they may need partial assistance in the ADL from the caregivers. They need someone to take care of them. They cannot cook. They need someone to feed or bathe or clothe them, or someone to keep an eye on them because they fall easily, or etc. So the challenges in these patients that they may not have control over meal choices. So they cannot decide what they want to eat today. So they entirely depend on their caretakers. If the caretakers give you a lot of food, then they'll get a lot of food. If they are given a poor selection of food, then their meal choices will be very, very limited. And they cannot check their sugar on their own. They may need caretakers to administer medications to them, and they may have a high burden of comorbidities. So they may have heart failure, heart diseases, eye diseases, kidney diseases, etc. So in this group of patients, we are aiming for them to, what we aim is to want to reduce the complications of the treatment, and then to try to keep the sugar level as good as possible without affecting them. So in other words, reduce hypos. So if there is nothing that you can remember from today's talk, the only word that I would like to remind is individualize. So how do you treat diabetics elderlies is individualized. So there should be no one single number of A1C for this group of cohorts. If the patient is very, very good, functionally independent, okay, memory is good, able to take care of himself, no comorbidities, low risk of hypos, then yes, an A1C of 7 to 7.5% would be wonderful. Okay, so these patients, their sugar is great. You want their sugar level to be tight, so they will have low risk of developing heart problems, kidney problems, eye problems, etc. But then again, if they are still functionally dependent, but they are frail, so they get hypos easily, or they have difficulty in walking, or they're actually demented, then A1C of actually 7 to 8% would be good enough. And sometimes you can actually aim higher, 8 to 9 or 10%, depending on the patient and the caretaker's expectations. But if the patient is really, really, really very elderly, and that he's not doing well, so you are primarily aiming for end-of-life care, at this juncture, there is no specific A1C goal. So at the time, as long as the patient is comfortable, there are no symptomatic hypoglycemias or hyperglycemias, and that's good. So at this juncture, once the A1C is not too bad, the daily sugar is not more than 12 or 15, the patient is comfortable, then that's good enough for the patients. So if you cannot remember anything, just remember that elderlies, the A1C should be individualized. So according to the patients, there's no strict number for them. Okay.
Sorry, can I
Yeah.
just ask you,
Hmm.
I know we are always worried about hypoglycemia in patients who are elderly.
Yep.
So we can afford to undertreat them in that sense, right?
Yep.
But is there, on the other hand, a risk of, let's say, acidosis from hyperglycemia?
Yep. So the main thing is that as long as the sugar does not go too high beyond 12 to 15, the
Okay.
risk of acidosis should not be there lah. So if
Okay,
the sugar is around 8 to 10, it should be okay for a
Okay.
patient who is terminally ill or very, very old. But
Okay.
if it's quite functional, quite good, then we should aim a sugar of 6 to 10 lah. Yeah.
Okay.
Yeah, sure. So what can we do, okay, in order to treat all these patients? So there are a few strategies for this. Then we just focus one by one. So for cognitive function, you will want to avoid very, very tight glucose control. So do not aim for A1Cs of 6% or 6.5 if possible. And we have known that from previous studies, very, very strict control actually worsens the outcome, especially in the cardiovascular outcome. So if the A1C is too low and they get hypos, there's a higher risk of getting arrhythmias and heart attacks. And in elderlies, hypos will worsen dementia. So like I mentioned, when you have hypos, you go to a stroke. When there's stroke, more of the brain cells will die out, and then your dementia gets worsened. Then with a worsened dementia, then you get hypos again. It'll be a vicious cycle. And avoid complex regimens, especially with insulin. So sometimes we play around with insulin. Morning, you use premix. Lunch, you use short acting, and then night you use a rapid acting. Use a long acting, super long acting, and the patients will get confused. Then they will forget the blue pen is for morning or the green pen is for morning. Yeah, and then they'll get confused. And then they wrongly inject, then they go into hypos. So try to make it as simple as possible. If possible, for oral pills, we will try to use a fixed combination once per day. And even for insulin, we'll keep it simple, unless the patient has a caretaker at home. So the daughter is there to take care of him or her, then the daughter can help to inject. So usually for the insulins, I'll ask, do you stay with your daughter or your son? Okay, then is it okay if the daughter and son injects for you? So before he goes to work, inject your morning dose, or when she comes home, inject your dinner dose and your prepaid dose. That'll be safer and easier, and the patients will really be happier, because elderly, they don't like to play with needles lah.
There are new regimens that can do weekly.
So far for insulin, we don't have that yet, but for GLP-1 agonist, yeah, it's a good option. But then again, it will cause anorexia. So sometimes you have to balance whether is it worth.
I see. Okay, it means they lose weight lah.
Yes, and also it is very heavy to the wallet lah.
Yeah, that's very true. That one, yes. Okay.
Okay, and then so we try to avoid treatments with high risk of hypoglycemias. So we try not to use long-acting sulfonylureas, or we try to avoid high doses of insulin. If an elderly requires a high dose of insulin, we need to always find out why a patient needs such a high dose of insulin. Because by right, the total insulin dose for a day should not be more than 1 unit per kilo. So if the patient is around 80 kilos, okay, if you calculate the insulin dose, he or she should not need more than 80 units per day. So if an 80 years old gentleman is injecting 20 units of actrapid, 20, add on with a 60 unit of insulin, total is 120 units per day, then something is very wrong. Either it's wrong injection, issue with the injection site, the pad has expired, or the patient does not inject at all, or there's a lot of frequent hypos, where the patient compensates with overeating. So we need to dig in and find out why, instead of just adding the insulin dose. Because when the patient goes into a hypo, then it will be very bad. And sometimes we can use alarms or pill boxes for medication reminder to help these patients. And also for depression, it may be good to screen them for depression, especially when the sugar is so difficult to control. And when you talk to the patient, they seem like, they are a bit no motivation. Some may even cry, or others because probably the loss of their partners, or they are being separated from their family members. The son or the daughter is not still with them, or they have financial issues. So sometimes we need to ask the patient, is there any difficulties that they encounter, whether they need to talk to someone, or maybe a short term of treatment may help to improve their mood. So another one is depression. Okay, others will be their physical disabilities. It would be good if the elderly can walk around even just at home. So sometimes you may need to help them to get hearing aids, walking aids, walkers, or glasses. Refer to the ENTs or the optometrists or the audiologists for that, or maybe for physios. Yeah, so to help them walk around, to do some limb strengthening exercises. Okay, and then if they have knee pains, what kind of knee strengthening exercise you can do, and also rehab may help these kind of patients. And also polypharmacy and medication non-compliance. So I will always ask my patient to bring all the medications regardless, including over the counters. You'll be surprised. They'll come with bags and bags of medications, and you check in there, okay, this uncle probably will go to clinic A and be given prandial and amlodipine, and then he'll go to clinic B and be given felodipine and HCTZ, and go to C and be given something else. So he'll be taking all these drugs all together, or he'll be jumbled up and get confused. So it's always good to ask them to bring everything during all their visits and update the list regularly. So write down, okay, uncle, today onwards, you will take this and this and this and this. The rest you throw away or you return it. So it'll be easier and better. And medications that have no benefits, you can just discontinue. For instance, you have patients that are taking vitamins for no reasons, okay, and or other pills. The hemoglobin is already 15, but they're still taking iron supplements because it's been given by other clinics for months and months. Okay, yeah. So another one thing is that when we see patients, we should always interpret the A1C with a pinch of salt. A1C in the elderly may not be the accurate parameter because they may have other comorbidities. They can falsely lower the A1C. For instance, most of them are anemic. They may have a concurrent nutrition issue. Some may have malignancy, okay, and some of them, they may have a recent transfusion, which may render the A1C inaccurate. Also, most of the elderly may have renal problems. They may end up with hemodialysis, or they're on erythropoietin therapy, which may cause the A1C to be inaccurate. So it is always better for them to do self-blood glucose monitoring where they check at home. I would tell my patients, uncle, auntie, you don't have to check every day. My minimum requirement is once to twice a week pre-breakfast. Of course, if you can check other timing is better, but that's the least you should do. Yep, and whenever you do, please record, because you can't remember, I know, you record it and show me. Okay, and there's a new device called a continuous glucose monitoring, like the Abbott free lifestyle. So they just plug it in and they'll monitor it for a week. So if the patient can afford, it is sometimes a good investment as well. I have one patient.
Is it called Libya? Is it called Libya or Libya?
Yes, Libre, yes.
Libre.
Yeah, yeah. But
okay,
it's quite costly lah. So it's up
can
to.
I ask this Libre, if if let's say the patient become hypoglycemic or hyperglycemic of a certain level, can it does it allow an alarm to go off?
So far, I don't think there's an alarm for that yet.
No alarm, right?
Yeah.
Okay.
And the drawback with using this is that because it measures the subcutaneous glucose level, not from the capillary blood. So there's around 5 minutes of a delay. So when you check the sugar, when you scan and you read the sugar at 9:30, okay, it actually reflects the sugar in the capillary at 9:25. So it's a 5 minutes delay.
I see. Okay, just you said that the presence of anemia or recent transfusion can change your HbA1c. Does it bring it down or up?
If you have anemia, then it will be falsely lowered. For instance, if your HB is 7 and your A1C is 5%, you see, wow, it's very good. But if we compare to a normal A1C of 11, 12, probably this uncle's A1C is around 8 to 9% already. So this is bad.
Okay, we'll go down now.
Yep. But if you are recent transfusion, then because when you transfuse blood, the HB, the hemoglobins are from someone else. If
Okay.
it's non-diabetics, then of course the A1C will look better.
Yes.
Yeah.
Okay. Makes sense.
Okay, so what do I usually do in my practice? So the first visit will always be the longest for diabetes. Like it will take a long time, especially with the elderly. So I will need to do a thorough assessment of a patient. Of course, you need to go through the diabetes duration and how was the control, how was it diagnosed, where was he treated, what medications is he on now, how is he dealing with the medications, any side effects, blah, blah, blah. Is he happy with it? How's the sugar control at home? Okay, who injects for him? Who administers the treatment for him? Any comorbidities, heart failure, chest pain, breathlessness, blah, blah, blah. Okay, so a thorough assessment as usual. And then, of course, we need to ask, how's the memory? So sometimes the family will say, oh, memory is poor. Cannot remember where he put his things. Or sometimes they say, oh, very good. Can still remember how much I owe him money, etc. Yeah. Some patients, they still remember. They forget everything, but they remember. Wow, my son
they
owes
will remember the money part. They cannot remember anything else.
Yep. And other geriatric syndromes, any hearing impairment, especially I ask about in males about prostate, and in females about urinary continence, because I tend to use a lot of SGLT2. So, and then after that, we assess the patient, and then we will need to plan how to treat the patient. So we need to set an acceptable A1C target goal. So for instance, if this patient comes to me with A1C of 14, then my aim will be to reduce the A1C from 14 to at least 10 without causing any hypos, and if possible, go even lower at the next visit. So you might need to go slow and steady without causing any hypos. So you don't have to aim too low. For instance, A1C of 7%, which is quite good, just maintain it. But if it's very high, they can go slowly, stepwise reduction of A1C. And choose a simplified treatment regime. If possible, I'll try to use a fixed combination if the patient can afford, and try to use a daily regimen. For instance, some DPP4 you have daily, and some you have twice a day. So usually I'll aim for the daily, which is easier for the patient. So instead of taking metformin, I will try to use the big ones, 1 gram, rather than using 500, because there's so much tablets and it's quite big, difficult for them to swallow as well. And for insulin, usually I'll try to use combination premix, unless the patient really has a very what do you call that? Very the meal times and the meal size is very variable. So they tend to get hypos, or the sugar is not controlled because of their diet or habits. Yeah. So what can we use? So now we have so many drugs to choose. And metformin is, of course, the first line because it is safe, it is cheap, and it is available everywhere. And some even say research has shown that it has so-called anti-aging, anti-cancer properties. But the main thing is,
does it work? Does it really work? The anti-aging and
it's just very small studies. There's no big scale studies to support that. But then again, some advocates are saying that it is so good that you actually should put it in the drinking water, just like fluoride.
Just like statin.
Yeah. So it's always the first line metformin, but need to be a bit cautious because it may cause anorexia and weight loss. In patients who are very old already, so skinny, you give metformin, then they have no appetite at all. And they may cause vitamin B12 deficiency, which is quite rampant as well in the elderly. So metformin is good, but need to think twice. If they're thin or very sick, that may not be the best option. Or sometimes they may have GI problems. Okay, some they have difficulty in controlling the bowel. So metformin, they take metformin, they get diarrhea or flatulence, anything. So they may not like it. Sulfonylureas is good as well. It is safe. It is efficacious. It works. You start as used, and the A1C definitely drops, unless the patient is non-compliant. But then again, the only thing is that you get a lot of hypos if you're not cautious. That's why for me, I would tell my students when I teach them, if I see you using a long-acting sulfonylureas on them, I will burn you at the stake. I'll tell them, because it is so dangerous, because we have seen so many patients coming for hypoglycemias and they're actually on long-acting like glibenclamide or glyburide, and some of them they actually develop neuroglycopenic coma where they don't wake up. So it's actually very, very dangerous. So since we have so many new generations of SUs like a dimicron or dimicron MR, so yeah, we try not to use sulfonylureas like glibenclamide anymore. Yep. And maglitinides, some practitioners they do use, but it's something new. And then it is good that it is very short acting, but it is usually given 3 times a day. So it can be like a mini insulin where you tell the patient you take it before you eat, but when you skip meal, you can skip the maglitinides. However, it is a bit expensive lah.
What can you name me a few drugs that is maglitinides? I've never heard of this word before.
The brand name, I think there's one is called Novonom by Novo Nordisk. Novonom.
Is a oral?
Oral is a repaglinide. Novonom.
Oh.
Yeah. So
Okay.
it is produced by Novo Nordisk. It is available, but I think because we don't really use it because it's expensive, so that's why nobody knows much about it. But it is available if you can find it. So sometimes patients who are like, I really don't want insulin, and I get hypos when I use SUs, and then my meal, I sometimes skip meals that I would try to give maglitinides. It works something like a rapid acting insulin. Yeah. So others can use a GLP-1 receptor agonist, where it causes low risk of hypos, and also it helps with weight loss. So if you get a overweight or obese elderly, you can try this, but it will cause GI disturbance like reflux, constipation, tummy upset, diarrhea, and it is very expensive. And honestly, the data is good, but then again, if you look in detail, the data, they do not really try it in a lot of elderly populations. So yeah, to say it is entirely safe for elderlies is still something that we can't be sure. So, but then it's still a good option to choose at the moment. DPP-4 inhibitors is one of my favorite diabetic meds in elderlies, because it is simple to use and there's no risk of hypos. Okay, but the only drawback is low efficacy. When you take it, you only reduce your A1C of around 0.5 to 0.7%. I will sometimes joke that, by seeing me monthly and scolding you monthly will bring down the A1C as good as the DPP-4 inhibitor. Because you nag and nag, the patient gets so fed up they listen to you. So this is really how inefficacious DPP-4 is. But then again, if you have nothing else to use, this is a good option. Or if patient is compliant to it, you can bring down as well. But the cost is another issue. It's not really that cheap compared to metformin or sulfonylureas. TZDs has gone out of favor. It does bring down your diabetes, your sugar control, and there's low risk of hypos. However, in elderlies, it's not an option, because it may cause edema, leg swelling, especially if they have heart failure. Sometimes the pedal edema can get.
Are you with us? Hello? Hello? Oh. Sorry. Hello? Sorry, the line went off. Ayo.
A bit cautious.
Oh, what? Sorry, you lost me for a while. I'm back. Can you hear me? Can you
pee out sugar? So yeah.
Can you hear me?
Okay, sure.
Sorry.
So, yeah. Sure, no problem. So I was talking about SGLT2. So it's a good drug. No risk of very low risk of hypos. It's simple daily using, and you have cardio and renal benefit.
Again.
However, in the elderly, you need to be very cautious because one tract infections, genital infections. Also, when they pee a lot, they may get dehydrated. So they get electrolyte imbalance, etc. And one thing that we always forget is if elderlies they have BPH or urinary incontinence.
Oh, I don't know why it's wrong with my Wi-Fi.
Oh.
Okay, can I ask you, this dehydration, when you say pee a lot, is it because of the UTI or is it the effect of the drug itself?
Effect of the drug itself. So when you take a lot of sweet drinks, you should pee a lot.
Oh,
Yeah.
but they shouldn't be taking so much sweet drinks, should they?
Yes. Yeah. So we'll tell patients if you pee, actually you should be drinking plain water and not sweet drink.
Okay.
So one thing is that they can get dehydrated, especially if they are on diuretics as well. If they're on furosemide, then it can worsen the dehydration lah. Yeah. And another thing I was mentioning is that a patient with BPH or what you call that, a pelvic floor dysfunction, if they are on SGLT2s and they pee so much, you imagine the torture of them running to the toilet like every half an hour or every hour. And when they pee and pee and pee, it will actually be very, very bad for them. So some of my patients they actually say, doctor, I don't want this. If I take this, I'll be peeing every hour. I cannot go anywhere. I just need to pee. So need to be a bit cautious among these patients lah. So they may not like it because of the frequency of the.
Oh, there is an increased frequency with SGLT2 inhibitor. I never knew that.
Yeah, because if the sugar is a bit high, you go into a urine and you start peeing.
I see. Okay.
Yeah, especially if they have BPH or pelvic floor dysfunction. And then they have osteoarthritis some more, they cannot walk properly. You expect them to go up and down the toilet. Yeah, it'll be torture for them. And finally, we have insulin, which is of course very, very efficacious. But then again, high risk of hypoglycemia, there's needle phobia, and then the problem of administering it. Okay, because elderlies, they cannot read well, they have problems with their motor skills, they cannot inject, so it's difficult for them. Okay, so back to my practice. So after you have chosen the right treatment regimen for them, you should also screen for other complications. Okay, always refer to the ophthalmology colleague because if they have cataract, which may impair their vision, they fall easily, they cannot read properly, they cannot inject properly, and diabetic retinopathy as well, and also ulcers, any numbness that makes them insomniac, okay, any postural hypotension which causes them to fall, and also the kidneys for proteinuria, and also sometimes if they're not too bad and their wife is still healthy and they will still need a healthy sex life, I will ask for erectile dysfunction. And also it's always
Can I ask you, this postural hypotension with this autonomic dysfunction, how do you treat it?
It is not easy. Usually we talk about what kind of measures, lifestyle measures that we can do. So for one is that you can use tighter stockings. That's one. Number two is that tell the patient that do not change your posture too fast. Don't lie down and then straight away jump up and walk.
Okay.
So I'll tell them go slow. When you're lying down, sit up, wait for 5 seconds, stand up 5 seconds, then you walk. So there are other treatment which is off the record. The gray in the gray book is that I can use fluorocortisone as well, but it's not easy to use.
Oh, okay. I'm asking you because I just recently saw a gentleman, elderly, 88, with paroxysmal AF. He has seen me for like maybe about 15 years now. And then recently he actually had a fall when he stood up. I didn't make any changes to his medication. And I actually, when I checked, he was sitting, it was 145. When he stood up, it was only 120. So it was a real significant drop. So now I'm just cutting back on his antihypertensive and see whether it gets better or not.
Is he on any alpha blockers for his prostate problem?
No.
Oh, yeah. There's another one concern. Yeah.
Yeah.
So for this gentleman, I'll probably tell him that, uncle, you should wear tighter stockings, which may help a bit.
Stocking, I think, a bit difficult. Okay.
When you sit up, when you stand up, go slow.
Yes, he knows. He tells me himself, if I stand up and I don't move for 10 seconds, I'm okay. Yeah, he himself can tell me that.
Yeah.
Okay.
Okay. And also reinforce on patient education. I will always explain to the family and the patient what I want, what I expect. I want to bring your A1C from how much to how much, and I'm treating you with this, how long I will treat you with this, especially if I use insulin. I'll tell them that I'm aiming for a rapid reduction. After that, I'll try to convert to oral. And then most important, I'll teach them about low sugar. What are the symptoms? What should they do? And then when they need to seek for help. So if the hypos are so frequent, then they should come back earlier. So what to do during hypos? They should have something to eat nearby in case, and always need to reflect, why am I getting so much hypos? Is it because today I ate lesser than usual, or today I am more active than usual, or I simply have been taking the wrong dose at the wrong timing, etc. If there's no reason, then the medication is the issue. Then you must come back and see me so I can adjust the medication again. So that's the most important part, because I don't want them to go into severe hypos and then they go into neuroglycopenic coma and a lot of complications lah. Or they fall, or they break a neck, break the leg, something very, very problematic for them. And also the patients and the family members' expectations. So you tell them that, sir, your kidney is already CKD stage 3. What I can do is I can treat your diabetes and slow down the progress, but you don't expect your kidney to recover completely, or etc. So they usually will explain to them clearly, they will accept lah. So they will not demand, and then they will not ask, why you do this, why you do that, why you want to inject me, etc. And also to encourage them to do self blood glucose monitoring. So our patients often has this mindset, they think that we want them to check 7 times a day. Actually, we just want once or twice a week, which is actually good enough. And whenever they don't feel good, hypo, you can just check. So to tell them what we want from them and what they can do, and then reach a consensus, actually they'll be happy. And of course, we're going to treat the other complications lah, like any hypertension, dyslipidemia, gout, etc., etc. So after that, during the further visits, I will check their glycemic control, usually a self blood glucose monitoring. But if the visit is more than 3 to 6 months, maybe A1C will be good with the other blood and urine parameters. Always ask them for drug side effects, and also routine screening for the other complications, which can be 3 to 6 monthly or yearly. And one last part is, don't forget the other aspects.
Again,
smoking do you good. Yeah, sometimes you often forget this. Just treat sugar, we forget that they smoke as well. The overweight and obese, we tell them, uncle, please lose some weight, it will help you. And also, if those who are really thin or sick, they may need proper nutrition and physiotherapy to prevent sarcopenia. And also, always actively screen for depression and mental health issues. And other things I always do is I screen them for vitamin D levels, which is very prevalent in Malaysia, which also is associated with the sarcopenia. With sarcopenia, less physical activity, they say difficult for me to climb up, to walk, so they do exercise and the sugar is bad. And finally, vaccinations. So as we know, diabetics, they are very immunosuppressed. And so you have a lifelong pneumococcal vaccination, 1 jab and that's it. So it may help them. So they're very scared. So sometimes it may take some time to.
I'm so sorry lah, my Wi-Fi is so bad. Can you hear me?
Okay lah, I've been breaking, but still not too bad lah.
Yeah, so sorry lah. I don't know what's wrong with this Unify these days. Okay.
Okay. So vaccinations for pneumococcal and also influenza. Others, they can consider, for instance, meningococcal, especially those who are going for Hajj. And also some they want to invest in a herpes zoster vaccination, which is also available now. Okay, so in the end, what I noticed is that most of the time, our elderly patients, they just want to chit chat with the doctor. So most of the time, they just want reassurance. They just need you to tell them everything is okay, uncle, don't worry, everything is well. Or sometimes you need to dig out and find out whether there's any burnout issues. The patients may be diabetic for 30 years or insulin for 20 years. They are so sick of it. They just want to vent out their anger and frustration. Or the caretakers has been there taking care of the mother for 5 years, every day have to inject for her. She cannot go out for holiday, cannot go out to watch movie at night. So they are just frustrated. So sometimes you just sit down and talk to them, spend extra 10, 15 minutes. Usually they'll be happier. Okay. So that's all for my brief talk today. So I'm happy to take any questions if there is any.
Okay. I think there are a few questions.
Yep.
Hold on.
Yep.
The questions were in the chat.
Yeah.
Okay. So there are quite a lot of questions. Number one, Dr. Tan from Docuity asked, for an elderly who is still feeding, which enteral feeding powder should be used to replace Ensure Go? And then I will add on, what is the problem with Ensure Go?
Ensure is not really indicated for diabetes because the calorie is higher. However, Ensure Gold is good because supposedly it has extra protein for muscle building and to prevent sarcopenia. So most of the time for diabetics, we recommend milks like Lucena or I can't remember the name, but a lot of companies, they have milk just for diabetics, but the protein composition may not be adequate. So sometimes I'll tell this patient, uncle, you just drink this milk and top up with 2 eggs per day, egg whites per day. So egg whites are actually a good source of protein for elderly. So egg whites.
Okay, we go on.
Yep.
Question number 2 is Dr. Tan also asked if a sedentary elderly patient is Madopa and rivastigmine and is gaining weight because of an increased risk of diabetes, what alternatives can you use to replace these two? I suspect this is for Parkinson's, isn't it?
Yeah. So unfortunately, I'm not a geriatrician. I don't really treat Parkinson's or dementia. Usually, what I can do is that we can give a feedback to our colleague and tell them that whether they have any other options to choose. But if you're talking about diabetic patients, that may help the patient with the weight. Or if it's a pre-diabetic patient, you may need to advise them diet, exercise, etc., or choose other drugs like metformin that can help. But for me, I'm not sure whether there's any other alternatives for Madopa and rivastigmine. From my undergraduate internal medicine knowledge that I still remember, I think that is first line for Parkinson's and dementia.
Okay. So Dr. Siti Ropaya asked, is hypoglycemic attacks, hypoglycemia frequent in elderly? Glucose level that won. I don't know understand what that won.
So for her question, yes, it can be quite frequent, especially in those with low functional or very frail or those who are not ADL independent. So glucose levels that won. Your body is designed to warn you when your sugar is low, for instance, less than 4. So in our guidelines, we take less than 4 as 1. But then again, in elderlies, it can be relaxed to up to less than 5. So for me, if the elderly is very frail and always hypos, I'll tell them that 5 is my limit. If your sugar is less than 5, okay, I will cut down on your insulin or your medications. Okay, that's 1. So it depends on the patient actually. If it's fit, then maybe 4. If it's a bit frail, maybe 5 or 5.5 is low enough for them. And there's actually this entity called it is called suddenly I have a thought block already.
But can I say that sometimes patients, a lot of patients in the elderly become hypo because they become septic or they have an infection and they took the medicine, but their oral intake or their appetite drop during the infection. It's also very common.
Yes, that is one of the commonest reason why elderly go to hypo. They don't feel well, they take medications, especially sulfonylureas or insulin, and they don't eat as usual.
Yeah.
The word comes to me, it's called relative hypoglycemia. So it is actually symptoms of hypos, but the sugar reading is actually not hypo. So how do you mean by that? So if the patient, his sugar is all the while 14, okay, and when you treat them, the sugar goes down to 7 to 8. For us, it is normal, right? 7 to 8. But then again, for this patient, because the body has not experienced 7, 8 for so long, it thinks that it's hypoing. So sometimes I'll tell the patient, if you experience hypos and you have a machine very near you, please check your sugar immediately. If it's less than 5, then yes, you are having hypos. Please eat something and find out why you're having hypos today. But if you are having hypos and the sugar is 7, 8 or more, please do not eat anything. Just drink plain water until you are very full. Or if you really cannot stand the sensation of hunger, just chew a bit of biscuit or a half piece of bread to help you. Because our patient have been taught, oh, hypo, must minum Milo.
Oh,
so
always
from
Milo,
a 7, Milo goes 17. Yeah. So we tell them, no Milos, anything, biscuit, fruits, sweets, just near you. No Milos, please.
Oh yeah, why do our patients always feel a need to drink Milo? Even when, let's say when I am, when they always tell me, oh, doctor, you better drink Milo, lah. You look pale. Okay, very funny.
Okay.
This Milo thing driven in the from generation after generation. Okay. So Dr. Mutu asked, hey, this one you already said with a pinch of salt. Already answered Dr. Mutu's question.
Yeah. So pinch of salt means that when you look at the result, you must always think, does it really reflect the patient in real? So your patient has anemia or has recent transfusion or anything else, or there's any factors that may give you a false result. So you should not believe the A1C. And yeah, that's the main thing.
Okay, I've just shared a Google form. Please put in your name, fill it up so that I can send it for manual submission of CPD points. Yeah. So Dr. Chu asked Dr. Tan asked, autonomic postural hypertension, treat with tablet Mestinon. What's Mestinon? I must check.
Mestinon is I think it is predostigmine, but I'm not familiar with using that.
I never heard before. Dr. Chu said, do mineral cortisone help postural hypertension?
Yes, fludrocortisone, you can use it to treat postural hypertension, but of course, there's a risk of hyperkalemia, there's a risk of hypertension as well. So of course, whether treating it is it worth treating it? Yeah, if the patient is really bad, yeah, then you might consider it. But if it's just very mild, I won't use fludrocortisone.
I almost have not seen one that is so significant other than my recent patient. It is not common, I would say, postural hypotension. Okay, we will take the last two questions. And one is Dr. Faslina said, for elderly patient, HbA1c of 9, who is insulin dependent on rapid and long-acting insulin, but enjoys snacking. How old is your patient? Between meals due to inability to eat regular size portion. Would it be beneficial to break down the pre-meal insulin further? So smaller dose, but more frequent?
Okay. So we have elderly patients on insulin, rapid and long-acting. So I assume it's 4 times a day, but enjoy snacking the meals. Okay. To break it down to breakfast, morning. So the thing about using insulin is that the insulin we have, the rapid acting, the atropine we use, actually it is not really rapid acting. When you inject, it takes around 20 to 30 minutes to start reacting, and then it may last in the body up to 4 to 6 hours. There's always a risk of getting hypos, especially if you use the rapid acting. But if you use very, very rapid acting, like what do you call it, glycine or aspart or those, it is very, very rapid acting, but still again, it may last up to 2 to 4 hours as well. So if you use more than 3 times, of course, there's a risk of getting hypos. So for me, is that
again,
the oral treatment that may help as well. Probably a metformin that may help with it, or a DPP-4, or sometimes if the patient is affordable, you can afford, you can use the GLP-1. Another option is that the combination of a long-acting insulin plus the GLP, the Soliqua. So far, I've been hearing from my colleagues, it actually works not too bad, because one is the risk of hypo is low, and there's a little bit of anorexic effect on these patients, so they might not eat that much lah. But I haven't really got a chance to try it out yet. So you can try other things, but I don't think that so many insulin injections will work. Should I tell the patients maybe you should not eat that much, but find out why the patient is actually eating. Why is he snacking so frequently? Is it because he's having a lot of hypos? Is your rapid insulin dose too high, or is there any other causes for that lah?
Okay, Dr.
So
Tan
the other words that sorry.
Sorry, go on. You want to say something?
So it is still so far not.
Ayo, my Wi-Fi is terrible. Can you hear me now?
Yes.
Okay, Dr. Tan asked, what's the daily calorie requirement for a sedentary non-diabetic elderly of 46 kg at 87 to reach 55? Wow, why so skinny?
So number one, we must make sure that there's nothing that's causing the patient to be so cachexic. There's no underlying malignancy or depression or something else. And number two is that this patient will need proper enteral nutrition. He will need to see a dietitian to actually assess his calorie intake. What is he eating every day? What he can eat? What is so based on the weight and his lifestyle, need to calculate his protein requirements. Easy to just to say how much calories he needs. So it will be best to co-manage with a proper dietitian, these kind of patients.
Yeah. Okay. Thank you very much, Kang.
Thank you.
Hope to see you at work one day.
Okay, sure.
I want to ask one question, last question.
Yeah.
Actually, I want to ask you, at what age do diabetes usually start?
Classically, type 2 diabetes is an elderly disease. So you should be getting it when you age. But nowadays, due to the unhealthy lifestyles and other reasons, we have diabetics type 2 as young as 12 years old, 13 years old.
Oh my God, so young.
Yeah, and they're usually very obese.
Okay, so most of the time, these patients are patients who actually, so patients who will usually get diabetes on a general basis after 55, 65?
By right.
Oh, okay.
Yeah.
Okay then. Okay, thank you very much. Bye, guys.
Thank you.
Okay, I'm going to stop live stream. And I'm going to stop recording.